All right. Well, thank you so much. So I wanted today's topic to be on neurofeedback. I want people to be more aware of the approach and kind of dispel some of the myths about it. Um, Wanted to share what it can do, what the science shows that it can do, and what it can't do, and also discuss the best practices. So first, let's talk about what it is. Um, so a few things I'm going to go over. What is neurofeedback? What is brainwaves? What is operant conditioning? What is the evidence behind it? What are the best practices? And at the end, who would we refer to? Um, so let's start with operant conditioning because that kind of sets the tone. So operant conditioning is when there's a behavior and we reward that behavior is increased. So it's kind of like how we treat a dog. A dog does something, say it sits down when we say sit, we give it a treat. Next time we say sit and it sits down, we give it a treat. And so now the dog is learning when I do this thing, I have this positive reinforcement. I'm going to do this more frequently. So with biofeedback, it's operant conditioning for our body, or neurofeedback, operant conditioning for our brainwaves. So neurofeedback is often called EEG biofeedback, but a type of biofeedback is, say, if I have a sensor right here and on a screen, I can see how tense I am. And then I can figure out visually, oh, if I do this, that tension goes down. So I'm getting feedback. Or even just with something as common as diaphragmatic breathing, you have one hand on your chest, the other hand on your belly. And doing this teaches you, oh, if I breathe this way and my chest stays still, and my left hand is moving, I'm breathing with my diaphragm. So even this is kind of like a form of biofeedback. So what does neurofeedback, what does this have to do with behavior? What does our brain waves have to do with behavior? Um, I think someone's got, there we go. Um, so neuronal activity, our brainwaves, has been linked with a lot of different things, state of mind, sleep, seizures, our alertness. So if we think about just kind of that simple curve, many of you might be familiar with this. This is just the arousal performance model, showing if we're under aroused, we're bored, we're not that interested, we're over aroused, we may be anxious, um, we may have a panic attack. So we have this optimum range of performance. So this is the physical side of things as well as the mental side of things. So with EEG, we can measure the mental side of things. We can see if someone is under aroused or over aroused. And then we can use operant conditioning to change that. So this is when our neurons are firing. Think about like your heartbeat. Your heartbeat kind of has this rhythm to it on a much smaller level. Your neurons have a rhythm to it. There's some that have slower rhythms. There's some that have faster rhythms. Well, these rhythms have to do with certain states of mind. So the slower waves, say 1 to 4 uh, per second, has to do with feeling tired, sleepy. Maybe 4 to 8, 4 to 7 theta waves has to do with daydreaming, creativity, distractibility. 8 to 12 per second has to do with feeling calm. And even then, there's people who say, well, 8 to 10 is different than 12 or 10 to 12. I won't go into that too much. And then beta waves. Beta is 12 to 20. This has to do with alertness. And if it's too much, anxiety. Um, so neurofeedback, all it is it's observing someone's arousal state. They're observing if someone is sleepy or if someone is anxious. And then they're giving them a reward so that they can be, well, maybe less sleepy or maybe less anxious. So the goal is to change behavior by changing brainwaves. So the the neurons are firing and the neuronal oscillations and the amplitude. Maybe we can change how someone feels. Maybe we can help them be more alert, or maybe we can help them feel less sluggish. So how this works is we have someone in a chair, we have an EEG, and they're watching a show, and we have a computer, and we program the computer. As this person feels calm, say the alpha wave in the parietal lobe going up, cause the screen to be bright. And as they don't feel calm, that alpha wave goes down, cause the screen to get a little bit dark. So the person is watching a show and the screen is getting bright and it's flickering, but it's flickering based on their brainwaves. So this person wants to watch the show, and subconsciously, their brainwaves are adjusting so that the screen will be brighter. You can also do this with video games. Maybe you'll go faster in a video game or slower. It's just a reward. So we can have this visual reward, but also we can have a sound. So we can increase volume of a movie and decrease volume of a movie, or we can have a reward sound, like a bell, or we can decrease it. But this is also important because if you have someone come into the office, they sit down, they're watching a show, and then there's this loud bing, maybe that's not rewarding. Maybe, maybe that's bothersome. So you want to know if something like that is causing the patient to feel uncomfortable, and make adjustments so that it's actually a positive reinforcement. So this would be a child watching a show, the show gets bright. So someone comes in, we can have an EEG or a cap, or it can be just specific electrodes. We program a computer and they just sit there and they watch a show, and their brain waves start changing so that the screen will be bright. That's all it is. It's just we're causing the brain waves to change. The person just sits and watches a show and they enjoy the show. If they're not interested in the show, it might not work as much. So there's things like this. It has to be a reward. So if the screen being bright isn't a reward, then we'd want to choose a different reward. This is an example of a training that was done on myself. So part of the day I was feeling fairly sluggish. Delta wave, that's associated with sleepiness. The beginning, you can tell that's fairly high. That's this black line. The theta wave, that's this blue line. That was also fairly high. I was daydreaming. I was feeling tired. This green line, it's the lower end of beta wave. Beta has to do with feeling alert. I wasn't that day. I was not alert. I was tired and sleepy and daydreaming and not alert. Well, over the course of about 20 minutes, you see that I became less and less sleepy, less and less distracted, and more alert. So we can objectively see these changes happening. Um, Now, when this is done over and over, it becomes long lasting. It takes 40 to 60 sessions for it to become long lasting. But you can have long lasting changes. Now, if someone is doing one training and then 3 sessions later they change the training and then they change it again, you might not get the long lasting effect because you're constantly changing what is being rewarded. So if we're going to make changes to the brain, we want to understand what's going on. We want to understand these brain waves. We want to understand what's going on in each individual's brain. So the the different parts of the brain are obviously responsible for different things. Um, there's parts of the brain associated with auditory processing, parietal lobe sensory processing, occipital lobe visual perception. So what's fascinating is someone might come in and they say, well, I'm feeling anxious. Well, there's several different parts of the brain that we know of that can contribute to that. So with anxiety, if they have this asymmetry in the frontal lobe where things are imbalanced, that can be associated with anxiety, particularly high beta waves right here on the right in the front, associated with racing thoughts. But also, what if it's more back here? Well, that's kind of a different type of anxiety, but still associated with anxiety. Well, what if someone has an inability to feel calm? So it's not that they're stressed all the time, but more that they lack the inability to calm themselves. Okay, that's going to be different. Also, that's going to be kind of low alpha wave in the parietal lobe. So if someone comes in and they say, hey, what am I supposed to train? Like, I want this anxiety to go away. Can you help? I've got several places I could maybe just kind of pick and choose, but I wouldn't really know if I hit it for a while. And so also, what if that's the wrong thing? What if I could make things worse? So what we want to do is we want to look, we want to see what's going on before we make change. Um, so we do an EEG. So we have someone come in, they put on a cap. We use the International 1020 system. This is a little bit outdated. You'll notice it's T5, T6 here, and that's now P7 and P8. But they come in, they put on a cap, and we look at all these different spots. We get a recording. Typically, we do a few minutes with eyes closed and then a few minutes with eyes open. Now, with an EEG, there's a lot that can go wrong. So this is kind of a delicate process. Um, but it's important for us to see what is actually going on. So this is what it would look like. Now, to kind of the non-trained person, this might just be like a lot of lines. But all it is in understanding this is just pattern recognition. So if you look at this and you're like, oh, this is a little bit overwhelming. Well, now makes a little bit more sense just with this picture on here. Now you see, oh, these two, this is the front. Oh, this is also the front. So these four. So at the top, we have the front, and it kind of makes its way back from left to right. So now, just with this, you can kind of tell if there's a big spike somewhere, you can kind of tell where it is. So from this, we're going to be looking at a few things. Like I said, delta, theta, alpha, beta, high beta, and also gamma. So delta has to do with strongest when we're sleeping, has to do with repair. Um, there's a lot I could go into about each of these. But high beta, we typically see this when someone is anxious. We see that more than just loud or strong alpha. Um, so if someone has lack of sleep for a while, what tends to happen is they kind of doze off and come to. And when they come to, you'll see this burst of high beta activity trying to kind of get them to wake up. Well, with the data, sometimes just the raw data or artifacted data, we can tell what's going on. We also like to use statistics, but even just the raw data. So this is right here, this is a 15-year-old female showing fairly normal activation when listening. I'm going to contrast this with a 14-year-old male with ADHD. And I want you to just see if you can tell the subtle differences between a non-ADHD kid versus an ADHD kid. Maybe sometimes it's not so subtle. Um, so this is what ADHD will look like. This is excessive alpha and theta. So what's interesting though with neurofeedback, we could take something like that and we could get it to look more like this, and symptoms will lessen. Not necessarily go away, but lessen. So a few years ago, I think it was 2013, the American Academy of Pediatrics came out and recognized that neurofeedback is efficacious and specific for the treatment of ADHD in children. A couple years after that, it became efficacious and specific for treatment of adults with ADHD. So efficacious, specific, that's nice, but it's not the same as evidence-based. Um, So studies show that it's efficacious and specific for ADHD. It's considered efficacious for depression, anxiety, even seizures, insomnia. So these are some of the things that can be helped with it. But these aren't all the time. There's certain situations where it may help. Um, so I'll get back to that. So with ADHD, actually this is more okay. Meta-analysis by Sturman. This was more evidence on seizure. This showed that people who had significant seizure reduction, an average of improvement exceeding 50%. Um, so this is particularly helpful for individuals who the anticonvulsants aren't helping. Now, neurofeedback doesn't help everyone, but it helps a chunk. So if an individual is having these seizures and is making life like miserable, this this is an option. Again, it's not evidence-based, but there is good statistics, good science behind it, so it's an option. Not yet covered by most insurances. Um, so with evidence-based, we would have to prove that it is not the placebo. So we observe changes in the EEG and we observe changes with reported symptoms. So with ADHD, a kid is doing better in school. We see that there's less theta wave than there used to be. Um, they're more on task, they're less forgetful, they're more engaged. Even with seizures, we observe that someone isn't having seizures as much. So we see the changes and the person feels the changes, but it's not yet to the point where it's evidence-based that we've proven it's absolutely not the placebo effect. So with the EEG, there's the raw data, and then there's taking that and there's putting it into a database. And with this database, we can see how far outside the norm someone is. So someone comes in and they say, hey, I have ADHD, I get distracted a lot. And I look at the raw data and there's no beta spindling, there's no other issues going on. I put it into a database and I see that the theta wave is way out here and they're like 4 standard deviations. Okay, they're a good candidate for neurofeedback. We know that in the frontal lobe, that being trained down, they're going to notice a difference. But there's some situations where people come in and everything's right in the middle. And if aren't any issues in the raw data, there aren't any issues with it being outside of the norm, neurofeedback's likely going to go from treatment to maybe peak performance. And even with that peak performance, I, I don't know how much someone would feel better with some of the standardized protocols. Um, so there's times where just someone might not be a good candidate for it. And their symptoms aren't associated with their brain waves. Their symptoms are associated with something else, and other treatments would be perhaps more appropriate. So with the different brain waves we have the lower end, we have delta, so just delta, theta. Basically, we would look at these frequencies and would see how far outside the norm each of these are. And with what we find, does it correlate with the research? So if we find something that's out here, but it doesn't really correlate with the research, and we're not going to do anything about it. We're not going to train it. If it correlates with the research on that person's symptoms, okay, then they would be a good candidate. So a QEEG can be used to, we can take the EEG, put it into a database, and then get these sort of statistics to see if someone is a good candidate. This is half of a page of a QEEG. So this is kind of the high beta range. This would be someone that would be a good candidate for using neurofeedback to treat anxiety. Basically, we would take this bandwidth and give them a reward as it goes down. We could also do some other things by increasing alpha wave or increasing a sensory motor rhythm while doing this at the same time. But this would be an example of someone that is a good candidate. This is an example of what ADHD would look like on a QEEG. This would be the theta. So excessive theta, this would getting lost in thoughts, being distracted, um, training that down would hopefully alleviate. And if I would see something like this, I'd be extremely surprised if it didn't. But that being said, nothing's ever 100%. So we'd see this. This would mean, yeah, this person's a good candidate. Likely, if we train that down, they will notice a difference in their distractibility. They'd be able to stay on task more. It's about 80, maybe 85% of people with ADHD have something that looks like this. We call it frontal slowing. So sometimes it's not just theta wave. It could be a little bit of alpha or it could be delta. But when that's too high, that's associated with, yeah, symptoms of ADHD. So we have biomarkers for things like ADHD, depression, anxiety. Um, so there's some things though that can be seen in a raw EEG that you can't see in a QEEG. So if you were to just use a QEEG and not look at the raw data, it might be a mistake. So in a raw EEG, you're going to see things like sleep spindling, beta spindling, mu, lambda. That's going to tell you a lot. That's important to have that sort of information. You're also going to see things like artifact, things that are muscle tension or something else. And if you just get the QEEG back and the person goes along with that and says, yes, this is what we're doing, this is what the computer says, you might be missing what's actually going on. So the best practice is the EEG should be reviewed by the clinician in addition to a QEEG. There are, I think this is a little bit out of order. There are some types of neurofeedback like infralow neurofeedback that may not necessarily use a QEEG. This is more working with below 1 hertz. This is working more with glial cells than neurons. But classical neurofeedback, that you would need a QEEG. Loretta, you'd use for QEEG. The Z-score training is where you take a group of areas and you just have this live database where it immediately compares it to the norm and it just trains everything to the norm. So there's Z-score training, which some people say it's better. Loretta neurofeedback, again, some people say it's better. Loretta is essentially triangulating what's happening on the inside of the brain. So you can look at the insula, for example. Now, you would think perhaps with this sort of math and technology to look at the deeper regions of the brain that people would get better faster. And certainly there's people who make those claims, but it doesn't. There's no advantages seen in Loretta training than classical training with one electrode. In fact, we have some people in Utah who have published on this very thing and shown that it's not better. Dr. Corey Hammond. But there are some cool things that like you can do with this sort of technology. So Brainmaster, you can have someone watching a show and sorry, my light just went off. That's distracting. You can have someone get a reward for what's happening at all the regions of the brain and a separate reward of what's happening inside of the brain. So now you can do this sort of Z-score, training everything towards the norm while training very specific areas. Fun, interesting, but really has not shown that it's an improvement over just the classical training. So going up, I'll skip that. Okay, so this is an example of someone that would be a good candidate with ADHD. They come in, we see theta wave across the board, and we see excessive high alpha. Oh, someone asked a question. Would this work if the person had many health issues, also has other things like PTSD? Yeah, so So what's hard is if someone has ADHD and PTSD, you're going to get executive dysfunction from two different areas. Both can impact the frontal lobe. But when it comes to what to train, um, those of you, for anyone who's familiar with the book The Body Keeps Score, written by Bessel van der Kolk, he did some research with the Othmers protocol for PTSD. And he had an electrode here and here, and he found that was helpful for people who had PTSD, also helpful for people who had relaxation-induced anxiety. So if we take PTSD, what they used to do is they would train this location, they would train alpha up and also theta. Well, there's some individuals that felt like their guard was being dropped. And then they had this sort of vulnerability. They didn't like feeling vulnerable, and so they would panic. So some people with ADHD, or not ADHD, but PTSD will experience that. And so there's a training that can help that. Again, you'd want to kind of get a look at what's going on first. But Van der Kolk showed that um, 20 sessions, there was a noticeable difference. We don't know if that's long lasting because the other research shows it's a little bit more. But you'd basically, with ADHD and PTSD, you'd have one protocol for one and another protocol for the other based on what's coming up. Now, most of the time, maybe what's coming up is just excessive high beta waves. You train this down and then they're less anxious, and you train SMR up and then they're able to be more focused. So yeah, sometimes you can do it in one depending on what's going on. But ADHD and PTSD, that's tricky. Those two together can be tricky and often go overlooked. So when it comes to a database, so this would be an example of like the QEEG Pro database. So there's 3 FDA cleared databases. There's NeuroGuide, QEEG Pro, and more recently iMedisync. With iMedisync, you have to use their hardware in order to use their database. But with NeuroGuide and QEEG Pro, you can use various hardware. So these are FDA cleared. So there's others that maybe will give you a 3-page report. Something like QEEG Pro, you can get like 150 pages, or NeuroGuide another 150. You can get a total of 300 to really sift through and see what's going on, which is fairly detailed. And then there's some that are not FDA cleared that give you 3 pages and really don't give you much detail. So in this would be, if you're wanting to look at what's going on, this would be a good one. So, all right, so let's look at what a QEEG looks like over time. And if changes last, so changes are long lasting, it takes 40 to 60 sessions. And let's look at also when is it a good idea to do neurofeedback and when is it not a good idea to do neurofeedback, because sometimes there's some situations where you want to avoid. So let's say someone has a sleep disorder. You want them to get that taken care of. Sometimes someone will come in, they'll do a QEEG, and we'll see within 30 seconds or so that they start to fall asleep. We can refer out for getting that treated, getting a sleep study done, because it's going to take the person so much longer to learn and incorporate all this learning from doing neurofeedback if they're not getting as much sleep. EMDR, therapies that take advantage of memory reconsolidation would cause a spike in delta waves. Now, if you're trying to do neurofeedback right after causing a spike in delta wave, that's probably going to influence the training. And there's times where everything's clean. A QEEG and an EEG show no abnormalities. In cases like that, this is not the perspective to be looking. You want to kind of find out where else these symptoms are coming from. In the cases where it does show up, great, we can work with that. But when it's not showing up, the individual might not notice much of a difference. And it would be difficult because what would you train if everything looks good? All right. When a QEEG shows an excess of where you would want to train, standardized trainings may not help. SMR, training sensory motor rhythm, if that's too high, okay, you don't want to train that up. If someone has beta spindling and you look at, oh, yeah, maybe the standard protocol of theta down and beta up for ADHD, maybe that would increase the beta spindling. Maybe that would accidentally increase impulsiveness. That's not good. So yeah, there's times where you don't want to do neurofeedback. It's important to always do a QEEG to not accidentally increase symptoms. Here's an example. So someone comes in and we do a QEEG and it looks like one of these. So it looks like this. So we see 12 to 15. We start to see that 12, 13, 14, it's pretty high. An SMR sensory motor rhythm training, a standard training would be training that frequency up. With this, you don't want to train that up. That would potentially make things worse. So by looking at the QEEG, you know, okay, we can't do that protocol. Maybe we can do something else, but we can't do that. So it's always important to review not just the QEEG, but the raw data, because there's things that can tell you, you can learn from the raw data. Here's an example of that. If we look at just the QEEG over here, oh, it looks like maybe there's frontal slowing at this point right here. Well, what's interesting about this point is you got a blood vessel right there. And what's coming up? This is heartbeat. That's not brainwaves. And to someone that's not trained, and if they use something like QEEG Pro and the Sarah program, which is automatic for editing this, but they don't actually look at this data, they might think, okay, you are a good candidate. We're going to train that down. No, that's not real. You have to learn what is real and what is not. You see right here, there's a little bit of squiggly lines at T3 and T4. That's also not real. That's tension. That's jaw tension from like TMJ. So if that was coming up, oh, maybe we should train that down. That high beta wave is associated with anxiety. No, in this case. So you want the therapist to have enough training to look at this data, to look at the QEEG, and then say this is the correct protocol. So standard protocol for ADHD, training theta down and beta up. Well, what happens if the individual already has beta spindling, which is linked to impulsivity? Would that be a good idea to train that up? No, no, you would make it worse. If you're changing someone's brain waves and you're changing someone's brain waves perhaps for a long time or long lasting by doing like 50 sessions, you want to really know that what you're doing is correct. So even though people will like, I don't think there's any FDA like reported side effects. There are for neurofeedback. If you Google like neurofeedback ruined my life, you're gonna see situations where someone went in, they said, I have these symptoms. They did not do a QEEG. They did a training, and now things are worse. That sucks. Like that's not the best practice. The best practice is to look at the brain, to look at the EEG, and to look at the QEEG so that the correct protocol helps instead of, oops, now this person feels worse. Like that's a big oops. We want to avoid that. All right, so best practice, we review the EEG, we review the QEEG, we take that into consideration with the person's symptoms, and from that and the research, we determine the protocol that is appropriate. And then when training, we want the therapist to regularly check in with the patient. If the person is just, all right, I'll see you, 50 sessions later. No, you want to check in every so often and have the therapist say, okay, how are you feeling? Where are your symptoms? Because there's a few things that can happen. Maybe someone plateaus, or maybe there's a bad electrode and the technician didn't realize it. So you want to check in to make sure that there's objective change and then also subjective change. And then you continue until you reach that point where someone reaches maybe 80% of their goal. So I tell people neurofeedback won't get you 100%. You can imagine what do you think this would look like? Think about 100% picture perfect. Now think about maybe getting 70% there. Um, that's just kind of my way of letting people know it's not going to get rid of everything. It can really help. 70% is a lot, but you can have symptoms be lessened, but may not necessarily go away. Practitioner also with additional considerations, neurofeedback is not regulated. So you could go to someone and they say, hey, I can help your ADHD, I can treat your ADHD, but they may not be licensed to treat ADHD. So you want to make sure that who you're going to, well, has the ability to treat you. It's generally a good idea if the equipment is FDA cleared, the database is FDA cleared, and that the practitioner is knowledgeable and experienced. So with QEEG, so this is used to screen people with neurofeedback, along with symptoms. Raw EEG determines protocols for neurofeedback, but also it can screen people for TMS, transcranial magnetic stimulation, or be used to adjust the location for TMS. People prominent in the field, Jay Gunkelman, will say it's a good idea to use a QEEG to screen people for even alpha stim, which can be used to kind of put the body into a rest and digest state. What I find fascinating is that it can be used as medication prediction response for ADHD. Jay Gunkelman did some research on this. It's held up fairly well over the years. So let's talk about that briefly. So let's say someone has excessive beta spindling. We know that stimulants may exacerbate that. So maybe if they already have this and it's already high, it's likely they may have that adverse reaction to a stimulant. Well, in cases like that, guanfacine could be helpful. Or let's say there's severe cases of beta spindling, gabapentin can sometimes be used. Low alpha peak, amphetamine may help more with that. If there's frontal midline theta, that's real, like methylphenidate or Ritalin can be very good for that. There's frontal alpha, SNRIs or SSRIs will help with that. So we know what the EEG looks like. We know what the medications will do to an EEG. So from that, that's where that kind of research developed. Okay, we know this is what the EEG looks like with these symptoms, and we know these medications do these things to an EEG. So that's where the research started of finding out, hey, can this be used to actually see if this would help? So what do symptoms look like after treatment? So let's take an ADHD person. So someone who goes to their car, they forget their keys, they go back, they go to their car. You know what? They forgot their wallet. They go back inside, they grab their wallet, make sure they have the keys, grab their phone, get in the car, start driving. You know, I can't see anything, turn around, go back inside, grab the glasses. So something like that, after doing neurofeedback, I've seen go from, someone in the morning having that multiple times to maybe 2 to 3 times a week. They go to the car, oh, I forgot this one thing, and they go back. So it can help a lot with something like working memory. But ADHD is a neurodevelopmental disorder that there's physical aspects of it. Having too many dopamine receptors, for example, having a smaller frontal lobe by like 10%, that's going to stay the same. Neurofeedback's not going to affect that. So there's some things that are just going to stay. But the severity of someone's symptoms can be hugely helpful. Someone asks, can trauma mimic ADHD symptoms? Yes. ADHD symptoms, you can have all the symptoms and still not have ADHD. So executive functioning is impacted by PTSD. With ADHD being a neurodevelopmental disorder, it means it's there throughout someone's life. But if there's ever an onset, it's likely not ADHD. Like if someone didn't have symptoms, they got a head injury, now they have symptoms, well, it's likely the head injury. Or they didn't have symptoms, they had trauma, that's likely due to the trauma. Um, all right, so let's look at what a QEEG looks like before and after. This individual had ADHD and a form of a head injury. After doing treatment, I think it was 40 sessions, this person reported that relationships were better, they were doing better at their job, they were doing better academically, in all aspects of their life. The ADHD treatment was very helpful. So we have this reported change subjectively, and we see this objective change. Again, we haven't proven it's not the placebo, but they feel great. They feel better. So these are examples of a QEEG where we see deviant activity afterwards. It's not there as much. This is an example where maybe there's just a little bit of excessive alpha and theta wave, well, alpha wave in the front isn't there afterwards. Sometimes after treatment, it doesn't look perfect. So this looks noticeably different, but there's still stuff there. So there's still some, so this person could continue to kind of relieve the symptoms even more. But it's not just the individual hertz. We also look at power ratios, like the theta to beta ratio, for example. That's important with ADHD. So we can see that there's differences from that. That's one way to look at things. Here's another, this is an example of, okay, there was high delta to beta. This is probably just a bad electrode right there. I don't trust it. This person had high alpha to beta. Afterwards, it's not there. So this is kind of what it looks like. So they've done a study where they did treatment. They did an EEG at the beginning. They did treatment. They did an EEG at the end. Then they waited a year and they looked at the EEGs and they were the same as when they stopped, meaning these changes, these EEGs, after they're done, after a year, it's still, those changes are still there after a year. Typically, if we see anything after 6 months, it's likely it's long lasting. This is an example of someone who had a lot of racing thoughts, a lot of anxiety. We see that it's not showing up as much, maybe in relative power, but not so much in absolute power. And you see there's these other things. I'm not really going to go too much into this, but as relative power, there's asymmetry, there's coherence, there's lag. Yeah, I won't go into that. So these are just examples of what before and after looks like. So we do see that this can create change. So when is it appropriate to refer someone? Well, someone has, typically, I would say if someone has anything that's treatment resistant, they have ADHD, and they say, you know what, my medication helps 8 hours a day, but my morning routine sucks. I get super flustered. And nighttime, I can't take the medication because then I can't sleep, but then I can't focus. I can't do things around the house, or I can't do homework. Okay, this would be great. So when there's treatment-resistant depression, this is a good, perhaps a good treatment option, treatment-resistant anxiety. When someone isn't responding to typical treatments, it's a good idea to look at the EEG and see what's going on. And from there, we decide if someone is a good fit. So Utah, who in Utah does neurofeedback? Lots of people. And there's even people like that do ILF. You don't need a QEEG, as far as my understanding. That's still helpful for things like anxiety. That doesn't help so much with the brain waves as much as helps in a slightly different way. Works more with the glial cells. Dr. Corey Hammond. I would feel comfortable sending someone to him. I'm very, very particular about, I want to make sure the person is like looking over the raw data and looking over the QEEG. Dr. Corey Hammond has spent years publishing. I think he has over 112-ish articles on neurofeedback. So I'd be good to refer someone. I will start doing EEGs again, but I imagine there's others. So one way to find, I haven't found any others, but I hope there's others that do this in that sort of best practices way. But people who have an international QEEG certification, that's going to let you know that they have some training. So people who have that certification will likely be doing QEEGs and looking at the QEEGs and hopefully the raw data as well. So in summary, 40, 60 sessions creates long-lasting change. It doesn't cure anything. It's a solid treatment option. It isn't always going to be helpful, but when a QEEG is used to screen, and someone's a good candidate, it can be noticeably helpful. It can be life-changing in a good way. All right. Questions. What did you want me to reiterate? Do you have any questions on neurofeedback, its efficacy? Insurances won't cover it here in some states like Nevada. They will, state insurances in Nevada. So like the Medicaid branches, as well as the marketplace will. How long is a session? What is the cost per session? So it ranges. So a session can be, you know, once you get going and you're actually doing the training, it could be 15 minutes to 30 minutes. Um, so yeah, but like the appointment generally is 30 minutes to an hour. So yeah, the cost, it can fluctuate. Some people are charging, I think, maybe 120 a session might be the average. Um, it can be 150. I know some people that may charge less. So, but typically it's around 150 to 120. The frequency of sessions. Typically people will do a session like twice a week, sometimes 3 times a week. And then sometimes there'll be some situations where someone rents, like if they get the training on how to do the neurofeedback themselves, they could rent it and do it daily. But then the therapist would need to check in and make sure, because maybe they have a bad electrode and they have a week's worth of trainings that just went kaput because it didn't do anything and the electrode was bad. So there's a lot of issues with just making sure that those are actually doing what we want it to be doing. Um, wow, there are a few questions. All right, so what other treatments are available when neurofeedback is not applicable to a client? So you just kind of go, like, say with anxiety, the medication route, therapy route, you want to find out where the symptom is. Is it anxiety because they have not learned to have confidence? Is the anxiety because they have past trauma? Is the anxiety, you have mechanisms of change, of memory reconsolidation with something like EMDR, or extinction with behavioral therapy, or maybe neither of those, and family therapy. And with secure attachment, everything's easier. So finding the root of the symptom is really helpful. This is just another avenue to see what is going on, to find that root and to treat that. Initial resources for additional study to become more knowledgeable. So you can look at BCIA, the certification, or QEEG certification, stress therapy solutions. There's companies like that, or School of Neurotherapy, that will kind of walk you through. You can sign up for like uh, their classes and you can learn about neurofeedback. What is my contact information? I think I'll allow Joseph to kind of send that out, maybe in an email or something. Um, how can one verify if someone is providing the service is legitimate and not a scammer? Good question. So that's where the certifications can be helpful. The QEEG certification, that will kind of let you know they at least have this minimum knowledge to do the QEEG. Um, okay. Should other treatment modalities be used with a client while neurofeedback? For example, DBT and neurofeedback, or is encouraged to focus on just the neurofeedback? You can do some treatment like DBT would be fine alongside it. It's just kind of the more trauma focused therapies that like EMDR, that same day, that's going to have an effect on the brain waves. So doing a session right after that, it's going to influence the session, so it won't be as effective. Does this work for traumatic brain injuries in the frontal lobe? So typically, depending if it's gray matter damage or white matter damage, we'll see excessive delta or excessive alpha. Um, this could be used to kind of mitigate mental fog, um, and to help with functioning, but the research is not it's not as good with traumatic brain injuries because it depends on where it is. So it's hard to research, but we do know that that soft tissue damage, we know what it can look like and that it can affect the brain. So even something like long COVID, you'd see excessive delta waves. So this is something that can at least help correct the arousal state. So I would say that this, as far as treatment, I don't know where the efficacy is for something like a head injury, but could this kind of help their arousal state so that they're more functioning? Yeah, yeah, I can.
Before we go any further, I just wanted to make sure that we addressed one other question. I saw that Paula asked earlier, besides QEEG, do most therapists do an intake questionnaire for other issues that can cause problems or side effects?
Yeah. So you need the kind of standard, not just the QEEG, but you kind of need like an assessment. Because if I have the QEEG, I might be able to maybe predict what's going on, but I don't know what's going on. I don't know what they want treated. So we need to take that assessment and what their symptoms are and match it up with a QEEG to see if they're a good candidate to treat those symptoms. Because maybe they have this something else going on, but maybe that's not really what they want treated. For example, I do a QEEG on someone, I look at the QEEG, and then I meet with them and I say, huh, from this, I would have questions for you about like dyslexia. And the individual may say, oh, yeah, and this actually happened. Yeah, I have dyslexia, but I don't care about that. I want to treat the ADHD. So like there might be something that I could see, but that's not guiding the treatments. It's what the individual wants. And so if all that came up was just that, then I'd say, well, look, based on everything else, I'm not seeing biomarkers for ADHD, so I don't think this is going to help that. So the QEG is always taken into consideration with the assessment. I suppose I didn't go over that as much because I assumed therapists would have that sort of assessment. Yeah, that assessment's needed. That is a part of the process to know if this is going to help. And someone asked about insomnia. Yes, it's considered efficacious for insomnia. But it's also interesting if someone comes in, we see 30 seconds, they're falling asleep, and then they have these bursts of high beta waves to try to arouse themselves and wake themselves up, where they kind of like doze off and come to. There might be situations where even though this could help for insomnia, um, I might refer out and say, hey, if you're falling asleep this fast, you might want to get a sleep study done. Talk to your doctor about this, kind of look at these other things. But typically, SMR, sensory motor rhythm training, can be very good for insomnia. All right. Thank you for your time, everyone.